from the American Academy of Pediatrics.
According to the CDC, about 30% of U.S. high schoolers have been sexually active.
New policy from the AAP offers guidance for pediatricians on counseling about contraception.
It's really vital for pediatricians to think about sexual and reproductive health as part of adolescent primary care.
Plus, we'll look at shifts in obesity treatment for children and adolescents after the 2023 Clinical Practice Guidelines.
What I hope happens and continues to happen is that people keep talking to their clinicians and seek out solutions for obesity that are evidence-based and rigorous.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a discussion about counseling teens on contraception.
Joanna, I imagine as young as Mira is, you probably are years away from even thinking about her options for reproductive health.
I wish that were the case, David. I actually am worried about it. You know, when I was younger, I had very painful periods. And so at age 12, I went on hormonal birth control to help with regulation of those. And I do wonder if she's going to need similar care and what access to reproductive health care will look like in the next 5 years.
I worry even for our adult daughters, but as a pediatrician, I also have to make sure that I'm doing my best to serve my adolescent patients. That's why I'm excited to have two new resources from the AAP, a policy statement, Contraception for Adolescents, and a technical report, Contraceptive Counseling and Methods for Adolescents.
Then you'll be especially excited to welcome back our next guest, Dr. Mary Ott, lead author on both of those publications. We spoke with her about counseling and contraception and also over-the-counter options for families last year in episode 208.
For those who don't remember this accomplished guest, Dr. Ott is a professor of global health and adolescent medicine at the Icahn School of Medicine at Mount Sinai. Mary, welcome.
Thank you. I'm delighted to be here.
Mary, it feels like a lot is at stake here with reproductive health care taking center stage in policy debates. What role do pediatricians play in addressing and supporting adolescent sexual health?
I think a key thing to remember is that adolescent sexual and reproductive health is a part of pediatric primary care. Pediatricians serve young people up to 21 years of age, and by 17 years of age, about half of young people are sexually active and have contraceptive needs. Additionally, there are young people like you were as a teen who may need access to contraception for health issues like severe menstrual cramps or heavy menstrual bleeding. Many of our young people on oncology and hematology services need contraceptives as part of menstrual health care. So it's really vital for pediatricians to think about sexual and reproductive health as part of adolescent primary care.
I know that adolescents' right to confidentiality and their right to consent for contraceptive care continue to draw controversy. Why are these rights so important?
So from an adolescent perspective, confidentiality helps with disclosure. Like if you think about it, kids who have confidentiality in their pediatrician's office are more likely to disclose a need for contraceptives and are more likely to ask for contraceptives. So for pediatricians to even get that information, they need to be thinking about confidentiality and offering young people confidentiality. Young people who have time alone with their pediatrician, which is linked to confidentiality, but even if state law doesn't support confidentiality, a pediatrician and parent can decide to give the young person time alone with the pediatrician. Kids who have time alone are more likely to ask their pediatrician about sexual and reproductive health issues, more likely to get sexual and reproductive health issues taken care of, and to feel a part of that care. So confidentiality ends up being a really key piece of care for teens.
But this spills over into other things too. And I think pediatricians do wonder, like, how do you keep this patient-centered despite barriers like the consent to care or access to electronic health records that families have?
So this is a lot of back homework for pediatricians in terms of setting up systems so that they're adolescent friendly. Confidentiality is certainly a piece of adolescent friendliness, and pediatricians can look at how confidentiality is dealt with in their practice. Many group practices will have a confidentiality statement and a confidentiality policy that they provide to young people and parents that says this is how their practice approaches confidentiality during adolescence. And it could be as simple as saying these issues will be kept confidential, and we request that we have time alone with the young person during well visits and during visits for sensitive issues. Confidentiality is also a systems level issue where pediatricians can look at their electronic health records and understand how parents and young people access the electronic health records. Many electronic health record systems like Epic will have two levels of access where the young person can have full access and the parent can have proxy access where they can get like limited access where they can get visits and message the providers. Other systems will be able to make notes confidential. And so I think from a pediatric standpoint, it would just be helpful to understand what are the strengths and limitations of your electronic health record system and how can you set it up to maximize confidentiality.
And what should you be saying to the teenager who is opening up to you about what can be kept confidential and what can't?
I recommend honesty in terms of what you can and can't keep confidential. While young people are more likely to disclose if everything is confidential, if you tell them something will be confidential and then need to break confidentiality, then you've lost their trust. And that trust is a critical piece of the relationship between the teen and the pediatrician. So, and kids understand this. Kids are capable of understanding complicated messages. You can say, I'll keep this information confidential, except in these circumstances, and let them know what the circumstances are when you would break confidentiality.
Many families who want reproductive health care options simply can't access them. These publications directly address health equity, and how can pediatricians make contraception easier for everyone to obtain?
Well, the first step would be to integrate it into a pediatric office and into pediatric visits. All pediatricians can learn about birth control pills, and pediatric offices can have birth control injections like Depo-Provera. Many pediatric offices have designated either a pediatrician or an advanced practice provider to be able to place contraceptive implants in young people so that the family can get their care at the pediatric office. I mean, pediatricians are really great. Young people trust pediatricians, parents trust pediatricians, and they're already using and accessing care at the offices. So it's one less step and can make contraception more affordable and accessible for families.
And then there's what contraception to offer to families. And last year you gave us an overview of the contraceptive landscape, but how can pediatricians stay current with their practices?
Well, one way to stay current is to follow AAP policy statements and resources. So the Academy's Council on Adolescent and Young Adult Health, it continuously updates their resources on contraception for pediatricians. So that's one source. The Academy also will usually have training in contraception or some other sexual and reproductive health topic as part of their CME offerings. But on a really practical level, what I like to do, and I do this myself actually, even as a specialist, is I look at like trusted websites that are patient facing and keep an eye on what's happening with these websites and what are they coming up with. So for instance, the national organization Power to Decide has a website called Bedsider, which has like this beautiful picture of different contraceptive methods. And if you click on it, it provides a description of the method in lay language. Other resources like the Reproductive Health Access Project have birth control information materials for patients. So that, sort of keeping up through the academy is one way to do it. Keeping up through some of these patient-facing materials and websites is also another way to do it. And the advantage to that is that you also know what your patients are accessing and can point your patients towards these materials.
Are there special considerations we could keep in mind for our gender-diverse patients?
Well, I think when we're providing contraception to young people, we've sort of shifted away from counsel from most efficacious to least efficacious, and counseling has really shifted to thinking about understanding the young person's preferences for contraception and then any contextual considerations. So in their stated preferences, I mean, some young people really don't want to be pregnant. And so they may prioritize effectiveness above all others. And then you would counsel based on that. Other young people want menstrual control, and may suffer from dysmenorrhea or severe acne and, want these medical side effects of the contraceptive method. Another group may want hormones. Another group may not want hormones. Some kids just don't like to take hormones. So understanding the young person's preferences ends up being really important. And it also means that no method is 100% off the table, because it's better for kids to use a less effective method than no method at all. I mean, the other consideration are their contexts. Is this a very young adolescent? Is it an older adolescent? Are there power dynamics within the adolescent's relationship? Are there issues at home where the young person might need to keep the birth control more private? And how available is sexual and reproductive health care in the state where the young person lives? Do they have access to contraceptives? Do they have access to abortion? And so then you take that sort of approach, you can then apply that to gender diverse youth. So understanding their preferences in a contraceptive method. A piece of it is education, that testosterone and estrogen alone are not contraceptives. A piece of it is understanding what their preferences are. So a young person who is a trans male may feel very strongly that they don't want an estrogen-containing method, and it may be counseling then revolves around other methods. They may strongly prefer to have menstrual suppression in addition to contraception. So I think sort of understanding that perspective. The other piece that is sort of specific to trans youth, but also sort of broadly for all youth, is thinking about it from a trauma-informed perspective. Young people who are trans and gender diverse have higher rates of trauma, including trauma around physical exams. So just having attention to that and awareness of that, and sort of asking the young person their comfort level will be important.
What can pediatricians do if they believe there's a certain form of contraception that would be really beneficial to their patient, but their patient is hesitant about it, or they don't believe it will be helpful for them? How can they kind of start that back and forth about what might be the best type of contraception for them?
Yeah. I think, Joanna, what you're getting at is an important part of shared decision-making, which is really a back and forth process. One of the things the pediatrician can do is get the young person's understanding of the side effects of birth control. There's a lot of misinformation out there. There's no editor on TikTok. I tend to ask young people, what have you heard about this method, and what have people's experiences been? And then you can ask, use motivational interviewing approaches. Say, can I ask your permission to provide you with some additional medical information about it? And so the pediatrician can explicitly address misinformation. The other thing is just keeping in mind, birth control decision-making is a process. I mean, young people will start one method, try it, see how it goes, and they may not like it. They may have side effects. And just being sure as a pediatrician that you set up a follow-up visit, that you talk to them about how they're doing on the method. I always tell kids they're not marrying their birth control method. I would like them to give it a good try, give it a couple months as long as their side effects aren't severe. But if they don't like it, they can come back and we can go through this shared decision-making process again and, see if we can come up with another method.
So, Dr. Wright, pediatricians across the country are currently facing vastly different landscapes in terms of what their resources are and what's allowed. Are there things that all of us can do to improve access and information for kids and families?
David, I love that framing of thinking about what a pediatrician can do rather than what's not available. Pediatricians definitely need to be aware of their state laws, what's allowed in their state, what's not allowed in their state, and state laws around abortion, contraception, Medicaid funding. But also pediatricians can do a lot. A pediatrician with knowledge of different types of birth control can open up the conversation with the young person and can discuss different options, including over-the-counter options. The last time I was on the podcast, we talked about O-Pill, which is available at pharmacies without age restrictions. Emergency contraception, similarly, is available over the counter without age restrictions. So there's a lot that pediatricians can talk to young people about and can use to sort of enable young people to take care of their sexual and reproductive health. The other piece is that many young people want to involve their parents or a trusted adult in these decisions. And so checking in with that young person and say, is this something you'd like to involve your parent in? And I've had young people myself who did not want the parent to be a part of discussions about their relationship and sexual practices, but definitely wanted a parent to help them be educated about a particular birth control method and help support their use of a birth control method. The other thing to keep in mind is that many young women also have medical conditions like dysmenorrhea or heavy menstrual periods, and birth control can be used both for medical reasons and for contraception.
Mary, this has been so helpful, and I know our listeners want to sit down and read both the policy statement and technical report because there's so much information in them. But before they do, can you think of any last takeaways for us?
Well, I have two key takeaways. The first is for pediatricians, as we start looking at sexual and reproductive health issues, is to think about not just our practices, but ourselves, what are our own biases and how do those biases express themselves? And it's not necessarily a bad or good thing. It just is. We all have biases. I know that I personally really want young people to be on effective contraception because I know that kids who are able to graduate from high school and attend college have better health outcomes. And I know that that's one of my biases. So I always keep myself aware of that when I counsel. The other piece is sort of we're using in a lot of pediatrics is shared decision making, sort of a recognition that the pediatrician is the expert on the medical part of the decision, and the young person, the adolescent, is an expert on themselves and being an adolescent. And sort of coming at it from that shared decision-making perspective is important.
Well, Dr. Marriott, thank you for joining us again to talk about this critical topic.
I really appreciate the opportunity.
To read the policy statement, Contraception for Adolescents, and the technical report, Contraceptive Counseling and Methods for Adolescents, go to aap.org/podcast. Coming up, we'll look at shifts in obesity treatments in the United States after AAP guidelines.
I do sometimes miss being in a general pediatrics clinic, David. I remember one boy I took care of. He was around 10 years old, and I saw him every 3 months during my residency because he was struggling with obesity.
It can be so rewarding to follow patients like that. Were you able to help him with his weight management?
Not really. At the time, there weren't many options to treat obesity. And so every 3 months, we would talk about diet and nutrition. I mean, really go into it. And we'd be tracking his activity, ways to exercise. But I'm not sure it made a big difference in the 3 years that I saw him.
Yeah, there's just only so far that counseling on nutrition and exercise can go. I wish we could do a deep dive into that case, Joanna, to discuss the social determinants of health at play, things like the neighborhood he grew up in and access to safe spaces to play. But I want to do something equally interesting and talk about a new article in Pediatrics called Shifts in U.S. Obesity Treatments After AAP Guidelines.
Oh, I remember when the new AAP obesity clinical practice guidelines came out in January of 2023. That was episode 144 for us. And we weren't the only ones talking about those.
We were not, and it's still something we need to discuss. So let's discuss with one of the authors of this new paper, Davene Wright. Davene holds a PhD in health policy and decision sciences from Harvard University, where she now works as an associate professor of population medicine at Harvard Medical School. She's also associate director of the Division of Child Health Research and Policy. Dr. Wright, welcome to the show.
Thank you for having me.
Davene, why write this paper? Were you hoping to see obesity rates declining or curious about changes in practice based on the 2023 AAP clinical practice guidelines we mentioned?
Yeah, I don't think we had any expectations about what we would find. I think it was mostly curiosity. We felt like the 2023 AAP guidelines around obesity, childhood obesity, were pretty significant, a significant turning point in the field. And we know that there's a lot of descriptive research out there about the prevalence of obesity among children and around anti-obesity medication use. And what we wanted to do is capitalize on this opportunity to do a quasi-experimental design. This is what we would call a natural experiment, and use real-world data to evaluate whether and how clinical practice changed after the guidelines were released. I think those sorts of designs give us the chance to understand what is or isn't working around current policy and what kinds of policy, intervention, and implementation strategies we might want to consider next.
So I imagine there were a variety of data sets you might have looked at to ask these questions on childhood obesity. Which one did you end up choosing and why?
Well, we ended up using data from Truveta, which is a health data and analytics company. And this work was actually funded by and conducted in collaboration with Truveta. Truveta has a internally funded division called Truveta Research that aims to advance research on important health and health equity topics like this. And GLP-1 use in all populations definitely fits the bill. Ignoring the affiliations, Truveta data is a good fit for this analysis because we've got a really large sample, so 120 million patients, which is about 1 in 3 people in the US. And the data come from a collective of 30 health systems across the US that includes both academic medical centers and community facilities. So that's a little bit more representative of how care is delivered across the country in the real world. And the data that we used here are EHR data, not claims data, which means that we have things like measured BMI, we can look at prescribing versus dispensing of medication, and a couple other factors that allow us to study this question with some degree of nuance.
And you looked for 2 outcomes based on the guideline recommendations: nutrition counseling or referral to a nutritionist, and pharmacotherapy. Did you see big changes when you were looking at this data?
So it depends on how you define big changes. We did see an increase in nutrition counseling over time, and we saw an increase in use of anti-obesity medications. We saw specifically a 65% increase in use of anti-obesity medications after the guidelines were released, but a 65% increase in a very, very, very small number. And so it goes from very, very, very small to very, very small. And so use overall just is not as high, I think, as the public discourse might suggest that it is.
You mentioned this growth in prescribing. It seems like we've seen enormous growth in the adoption of GLP-1 medications, even since those guidelines were released. Are GLP-1 medications as big a deal in pediatric care as they seem to be in adult medicine?
Well, so the guidelines specifically only recommend, I think, 2 GLP-1 medications, which would be liraglutide and semaglutide. We did not look at tirzepatide, which has not been approved yet in pediatric populations. So there were a couple drugs that we looked at, including metformin, which is the most commonly used drug. Topiramate is another one, and a couple others that are a little less common. What's really nice and really fun is that this paper includes a heat map. So you can see how the changes in prescriptions change over time in a way that you can really see that decrease in use of metformin and a shift to an increase in the use of semaglutide.
And how many of these changes do you think really stem from AAP recommendations versus just a greater acceptance of multiple ways to treat obesity?
Yeah, I think it's a little bit of both, and it's hard to know what was really driving it here. Given that there are just common trends as well as recommendations, it's hard to disentangle those two things from each other. But I also think that the fact that the AAP made these recommendations speaks to the fact that there is this discourse that's happening in the public around these medications. And it's useful for expert bodies like the AAP to provide some guidance to clinicians and to families about what can be done, and reviewing the evidence that's out there and balancing the evidence against the risk and thinking about what will be best to improve population health on the whole.
And looking forward from these trends, how do you hope weight management in children might change in the next 5 years?
Well, I mostly am really excited that this conversation we've been having, I think, has made it more socially acceptable and empowered people to reach out to their physicians to talk about obesity and to engage in a conversation. And really what they should be doing is engaging in shared decision-making around what the options look like and what might work best for this family, what their goals are, what their values are. And so what I hope happens and continues to happen is that people keep talking to their clinicians and seek out solutions for obesity that are evidence-based and rigorous and likely to have some sort of an impact. What's really important as a researcher is that we have more data so that we can understand the health impact and safety of anti-obesity medications in pediatric and all populations. As a decision scientist, specifically, I'm really hopeful that we can get more information about what effective conversations look like so that we can develop decision support tools, both for families to talk to their doctors and for clinicians to talk to families to discuss obesity treatment options. You mentioned earlier, Joanna, people getting nutrition counseling, and intensive health and behavioral lifestyle therapy goes beyond that. It involves nutrition counseling, it involves conversations around physical activity. It actually specifically says that you need to have 26 hours of contact with a professional who's giving you guidance on things like nutrition, physical activity, behavioral strategies like monitoring your food intake, like engaging in goal setting and how to engage in problem solving as a family to improve your behaviors, and also guidance on things like screen time. But these programs are really, really intensive. They do, by definition, currently require an in-person component. And that is tough for people who live in rural areas, for people who have less access to transportation. And so my hope is in the future that we have some telehealth options, as well as options that are culturally competent so that these interventions can be distributed more broadly. I also think it's worth saying that the recommendation from the AAP was not to just give kids anti-obesity medications, but rather to give children access to anti-obesity medications, which are to be used in conjunction with behavioral treatment. And that's a really, really important part of this conversation.
You know, Davene, this paper is just a really interesting look at how AAP clinical practice guidelines may slowly begin to influence pediatric care. But do you have any last takeaways for our listeners before they go read it?
Yeah, so I think the takeaway I would want people to get is we have seen large increases in use of anti-obesity medications, but it's still extremely rare. And anti-obesity medications are primarily being used among adolescents with severe, what we would call class 3 obesity.
Dr. Davene Wright, thank you so much for joining us today.
Great. Thanks for having me. This is very fun.
To read the paper, Shifts in U.S. Obesity Treatments After AAP Guidelines, visit our website at aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, you know, we mentioned earlier this year that I'm finally a real hospitalist. I got board certified and I'm so proud of it. And I celebrated by going to the Society of Hospital Medicine's Pediatric Hospital Medicine 2025 meeting. I only ever do like the state and national pediatric meetings. I've never done a specialty meeting because why would I? But it was so exciting to just spend a few days learning about this thing that I'm doing now and being around a bunch of other people who do it and sharing stories and ideas and thoughts. And it was just a blast.
My Say Ah is about some of my general pediatrician skills too, David, because I like to think the podcast helps me keep them up. But Zelda, unfortunately, so we were playing with her and we were outside and we went to the beach and she started to get this rash. And I was like, wow, this rash looks familiar. But I was like, oh, it must be just from like the sand at the beach. And then it was on the bottom of her feet. And I was like, oh no, like, did she get burned because the sand is really hot? And then I'm holding her and my oldest daughter, Mira, is like, she's drooling on you. And I was like, oh, she doesn't drool. That's weird. And then I was like, she has hand, foot, mouth. I mean, that was why I was like, that was your second time having it. So it was enlightening. And I was like, well, I got to it in just like a few hours.
It is miserable, though. How's she doing?
You know, it was her second round, and she is a trooper. And she really didn't seem fazed by it. So, yes, it can be miserable, but it also can be okay.
Well, I'm glad that she's okay, and what a great review. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll bring you the August edition of First Up.
We'll speak to the new editor of Pediatrics, Dr. Alex Kemper. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.